Hi, happy Thursday, everyone. I have 2 o'clock on my computer clock. I'll give folks just another minute or two to log in and we'll get started. But in the meantime, I will leave you with a couple of housekeeping reminders. We'll get started in just one more minute. Thank you. Hi again, it's Amy Haddad. I just want to test and see if my audio is working okay. I'm going to ask if it sounds better. Okay, great.
Much better.
Okay, I closed the windows. I think it was the cicadas. So happy Thursday, everyone. This is the June AMCHP National Policy / COVID Town Hall. I know a lot of folks were joining in last week on our AMCHP conference. So thank you to those of you who are giving us back some more time today. I see we have fewer attendees than usual, but again, perhaps it's because we're just coming off of conference or people are starting to take vacations. Regardless, our webinars are always recorded and we'll be sure to share the information out later. So we'll start with an AMCHP policy update. We'll be joined by Laura Kavanaugh from MCHB. Then we have a presentation after the MCHB update, sorry, it's not in the bullet points, about Michigan's own experience with adolescent vaccination. We have a special guest today to talk about home and community-based services, and then a couple of AMCHP announcements. So I'm going to first turn it over to my colleague Allison Northrup, sorry, to give us an overview of the President's budget proposal.
Thank you, Amy, and hi, everyone. So last Friday, the President unveiled his full budget request for the upcoming fiscal year, federal fiscal year 2022. And I'll share some top line numbers from the budget for maternal and child health programs today. There's more detail on these slides than I'm going to go through, but you'll get the slides as a follow-up to this call. And then we'll also, AMCHP will be posting this information in member briefs and likely a standalone document with some summaries. So the big takeaway first is that the President's budget proposes $822.7 million for the top line number for the Title V Maternal and Child Health Services Block Grant. This would represent a $110 million increase above the FY21 level. That is roughly a 15% increase, which would be huge for this program. And broken down between the State Formula Fund and SPRANs, the increases are a $29 million proposed increase to the Formula Fund and an $81 million proposed increase to SPRANs, or Special Projects of Regional and National Significance. And I'll just talk through those SPRANs increases quickly. So within HRSA, the SPRANs increases are part of an HHS-wide proposal called the Improving Maternal Health Initiative, and this is to address maternal mortality in the United States and eliminate racial disparities. And so the Title V block grant is part of that initiative. And within SPRANs, the budget would propose a $30 million increase to the state maternal health innovation grants, $5.3 million increase for the Alliance for Innovation on Maternal Health, a $1 million increase for the Maternal Mental Health Hotline, a new program started last year, and a new proposal for $25 million for a pregnancy medical home or integrated services for pregnant and postpartum women program. Next slide, please. 3 more program new funding lines proposed as part of this Improving Maternal Health Initiative, early childhood development, expert grants for pediatrician offices, implicit bias training for healthcare providers, and a National Academy of Medicine study on essentially implicit bias training for healthcare providers. Next slide, please. Outside of the block grant, but still part of this Improving Maternal Health Initiative, are new investments in RMOMs within the National Health Service Corps, additional investment for the screening and treatment for maternal depression program. Next slide, please. One more, there we go. So these are a quick summary of some of the other programs at HRSA within the maternal and child health account that many of you also utilize these funding streams. A couple of increases, no decreases, which is a bright spot throughout this budget, I will say. Mostly level funding for these programs, but a plus up for autism and other developmental disorders, and a proposed plus up for emergency medical services for children. At CDC, you can go to the next slide. At CDC, there's one of their programs is also part of this HHS-wide Improving Maternal Health Initiative. That's the State Maternal Mortality Review Committee funding within the Safe Motherhood funding line at the Division of Reproductive Health. A proposed $26 million increase to this program. Next slide, please. Several increases at some really important programs at CDC. Plus ups for the Surveillance for Emerging Threats to Mothers and Babies program. Significant new investments in public health data modernization, the public health workforce, a new initiative that started this current fiscal year, social determinants of health, with a teeny tiny $3 million investment, significantly proposal for an increase, a doubling proposed proposal for research related to reducing firearm injury and mortality, and an increase for childhood lead poisoning prevention. Next slide, please. Okay, just a reminder that the president's budget is a proposal. Ultimately, Congress holds the purse strings, has the power of the purse, and will write the appropriations legislation for the coming fiscal year. But the president's budget really kickstarts that whole appropriations negotiation process and puts out a marker for what this administration would like to see in what Congress writes. Next slide, please. And so here's our tentative timeline for appropriations. We've now seen, as of May 28th, the president's full budget request was sent to Congress. Starting this month and into next month and possibly into later in the year, we'll see the drafting and markup of appropriations legislation in both the House and the Senate. We are running later this year than is typical, and that is not uncommon for a first year of a presidential administration. The House, as is also typical, is running a bit faster than the Senate. The Senate has not required its appropriations priorities from members yet. That deadline is still upcoming on July 8th. Next slide, please. And that's, I will stop there. I know that was a quick run through of the budget and appropriations, but we have a lot of content today. So I will hand things over to Amy for another authorizing bill update. Thanks, Amy.
Great, Allison. Thank you so much for that overview. And as she mentioned, we'll be sharing that all in some written communications coming out soon as well. Of course, this is just sort of a guide and an indicator of where the administration's priorities are. Hopefully by next call, we'll have a better sense of where the Appropriations Committee is looking. So we also just wanted to let you know that since the last time we had one of these calls, there's been some congressional activity on authorizing bills related to maternal and child health. On May 12th, the House passed the Protecting Moms Who Served Act, a bipartisan bill aimed to improve maternal health for women veterans. And on May 25th, the Senate Health Committee passed out the Rural Moms Act, Maternal Health Quality Improvement Act, and the Pump for Nursing Mothers Act. So if you're interested in learning more about those, we certainly have more information. They'll be in member briefs as well. But these are all exciting movements on the maternal health as authorizing side. All right, with that, I'm going to turn it over to Laura Kavanaugh, Deputy Associate Administrator of the Maternal and Child Health Bureau.
Thank you so much, Amy. It's such a pleasure to be with you this afternoon. If you could go to the next slide, please. I wanted to provide an update in a number of areas for you this afternoon. The first is to make sure that you are aware of the State Systems Development Initiative Maternal Health Enhancement Grants. These are available, the applications are due July the 2nd for awards of up to $60,000 to improve state data capacity for the Bureau's Alliance for Innovation on Maternal Health, or the AIM program. If you have any questions about eligibility or what we intend for these programs, please contact Kim Sherman at the number and email listed on the slide. Next slide, please. And you can advance several more there. I just wanted to share, as you are all well aware, that the rates of routine vaccinations dropped precipitously at the beginning of the pandemic, and they really hit a low in May of last year, May of 2020. Vaccine distribution rates have been slowly coming back since then, but as of January of this year, they're still well below what they were prior to the pandemic. And in addition to reductions in vaccination efforts, there are racial and ethnic differences in missed well child visits as well. Notably, there are much higher rates of missed well child visits in households of color. These also existed prior to the pandemic and have been exacerbated by the COVID-19 pandemic. Well child visits are an opportunity not only to provide vaccinations, but also to conduct health assessments, to do developmental screens, and provide counseling. So we want to make sure that we're both focusing on well child visits as well as vaccinations. Next slide, please. MCHB has a number of activities underway to try to encourage well child visits and immunizations. We're engaging with diverse stakeholders to share information about the importance of these visits. We're engaging with community health centers, state Medicaid agencies, childcare providers, employers, and you, the Title V directors. Starting next week, Dr. Warren will also be participating in a radio media tour, and we also have sponsored the P4 Challenge, and I'll talk about that a little bit more on the next slide, please. So the Promoting Pediatric Primary Prevention, or P4 Challenge, Dr. Warren has presented on this in previous webinars. I wanted to provide an update that we received 241 submissions for the phase 1, and 50 phase 1 winners were announced on May the 7th. Each of those winners received $10,000 to deploy their proposed approach. Next slide, please. Those 50 winners represent 23 states and 19 community health centers. They also were represented in academic medical clinics, mobile units as well, and a number of community-based partnerships, including with churches, with fire departments, and community organizations. Also importantly, a number of them were addressing adolescent health as part of their intervention. Next slide, please. And relevant for adolescents is that the COVID-19 vaccine is now recommended for those ages 12 and over, as recommended by the CDC's Advisory Committee on Immunization Practices. Next slide, please. As Title V directors, you have an incredibly important role in promoting the COVID-19 vaccines in youth. We encourage you to work closely with your state adolescent health coordinators and your immunization managers to promote and ensure consistent messaging on these vaccinations. I know that you also regularly collaborate with key partners like your state and local AAP chapters, your state Medicaid agencies, local education agencies, and state and local early child and education providers. Next slide, please. There are a number of resources regarding vaccinating MCH populations that I want you to be aware of. We sponsored a recent webinar, Strategies to Promote COVID-19 Vaccine Among Adolescents and Their Families, where our representatives from our leadership education and adolescent health training programs presented how to refine messaging for families and for adolescents regarding these vaccinations. The recording is available at the, I'm sorry, could you advance to the next slide? I skipped over one. The recording is available at this site. I'm sorry, if you could go back one, there's another resource in addition to that, adolescent health. Sorry about that. AMCHP recently launched a new webpage with additional resources on vaccinating MCH populations as well. The URL is provided here. It provides access to messaging and resources regarding vaccinations. It highlights innovative approaches and includes bright spots, and you'll hear from one of those bright spots today from Michigan. So if you could advance 2 now. Thank you. So we're hearing from you about the wonderful ways that MCHP grantees are getting out the word. You are engaging with community partners to help immunization management for infants, to host nurse-only immunization clinics, including using catch-up schedules, and that was shared by Arizona. In Maine, provider practices are receiving incentive payments for each child who receives both a wellness visit and a vaccination. In Massachusetts, mobile health units are providing comprehensive pediatric care, including immunizations within the community. And in Tennessee, they are sponsoring a series of community events where they're providing COVID-19 vaccines, regular routine pediatric immunizations, diapers, food boxes, and TennCare registration all together. Next slide, please. So today we're very happy to have Stephanie Sanchez, the Quality Improvement Coordinator with the Division of Immunization from Michigan Department of Health and Human Services, who's going to share their best practices. If you have a bright spot that you want to make sure that we highlight on the website and elsewhere, please share that with Sarah Henneke. Her email is provided here on the slide. Thank you so much, and I will turn it over to Stephanie.
Hi, thanks so much, Laura. Good afternoon. And we want to say thank you for inviting Michigan to share about our various efforts being made to help get vaccines back on track for people in Michigan. Next slide, please. So today, as I was introduced, I work for Michigan Department of Health and Human Services and their Division of Immunization as their Quality Improvement Coordinator. My primary role, previous slide, please. Sorry. My primary role is working with both internal and external stakeholders with efforts to increase immunizations in Michigan. Today, I'm going to talk pretty quickly in hoping to showcase some of Michigan's efforts and the strategies that are being used. Next slide. In response to the COVID pandemic and the development of the COVID vaccine, Michigan's team of epidemiologists have created a coronavirus website for Michigan, as well as a COVID vaccine dashboard in Michigan, shown here. The COVID vaccine dashboard is available to anyone through the internet, and it contains much information and data, and it's interactive for the user. Next slide. This slide shows the state map current as of June 2nd with COVID vaccine series completion coverage by counties. This map can easily be changed to show the initiation levels of the COVID vaccine, can focus specifically on a geographic area of one county or several different counties. Next slide. Along with our epidemiologists, we also have a group of immunization nurse educators here in Michigan, and they've been working diligently with assuring our providers have current and accurate information. We have a COVID vaccine provider website, and you see the website shown on this screen. It contains resources, data, and materials for providers and their staff. Next slide. Within this Michigan COVID vaccine provider website is a plethora of information, including a clinic preparation checklist and a resource toolkit. Our education team holds several noontime knowledge webinars. These are 1 hour live, but also recorded webinars available to any providers in Michigan. The webinars contain current information, whether it's about the COVID vaccines, the EUAs, storage and handling, ordering, or about newly reported possible adverse reactions, how to redistribute, several different things. So it's great that it's recorded and available online for people to access later on if they're not able to attend it live. Next slide. So we know what gets measured gets attention. Therefore, looking at and reviewing data is key with assuring that efforts make an impact. And for us, it's with increasing vaccinations. So as Laura mentioned, everyone, including us in Michigan, has seen the vaccination coverage levels, both for child, adolescents, and adults, steadily decline throughout the pandemic. Vaccination coverage for Michigan children shown on this slide is for 19 through 35 months of age, showing the how much they've declined between April of 2020 and April of 2021. The data on this slide is from our immunization information system referred to as the MICR. That's the Michigan Care Improvement Registry. And we are an opt-out registry, meaning every birth that is recorded in Michigan and goes through our electronic birth certificate information or through our vital records, that birth information does get loaded into the registry, and all vaccinations are that are administered or given in Michigan by anyone, a pharmacy, an urgent care, or a physician's office, they have a 72-hour requirement to get that immunization information into the registry. Next slide. Michigan also sees disparities in vaccination coverages. This slide is again for child vaccines, and it's as of April of 2021. As Laura had mentioned, this did not start because of the pandemic. We saw disparities in childhood, adolescent vaccinations pre-pandemic as well. Next slide. This slide does show some adolescent data specific to the HPV, and this is from our immunization registry. And it looks at the difference of initiation as well as completion levels of the HPV vaccine here in Michigan for 13-year-olds and then also for 17-year-olds. There's also much data that's used for analysis from both the National Immunization Survey and also the National Immunization Survey teen version for coverage levels and also for disparities. And that is a presentation unto itself. So I'll forego any more discussion about this due to sake of time. So let's go ahead and go to the next slide. Knowing both that the vaccine ordering and vaccine administration has declined during the pandemic here in Michigan, we've created a call to action type of effort, an initiative, where we created 2 letters. One was with a target audience of physicians and providers, and the other letter has a target audience to parents and guardians of school-aged children. So this slide is that provider letter, which includes some of the data that I talked about or showed earlier, as well as a few strategies that, if implemented, could assist with getting patients back into the office, encouraging and scheduling annual physical exams, and getting them vaccinated. It also talks about how they should and could generate recall letters from our registry for the patients that they see at their practice that are currently overdue for vaccines. Also, a strategy is using the available quality improvement reports in the MICR that's at the practice or site level. It assists them with identifying from specific age groups and then contacting those patients or families to schedule needed appointments. Due to this pandemic and the stay-at-home orders, we know that there's many aspects of healthcare that have not occurred, and that the providers, their staff, and their patients need to know that it's safe for them to return to the doctor's office for medical care. Next slide. This slide shows the second letter, which is the focus audience of the parents and guardians of school-aged children. The letter reminds parents that there's preparations are being made by many entities, including them, the parents, to help get back to normal with activities here in Michigan, including going to in-school or maybe still virtual, in-person school or virtual, participating in sports, and also attending group gatherings. Part of the parent preparation is to have their children protected with all ACIP recommended vaccines, which helps protect them from many diseases. We encourage an additional flyer or resources to be made available or sent with this parent letter. On this slide is that child immunization schedule for the 7 to 18-year-olds. Both the parent letter and the provider letter have been distributed from our Division of Immunization to several different partners and stakeholders, to include our local health departments, Medicaid health plans, our teen and adolescent health centers, school-based clinics. Primary Care Association of Michigan have distributed it to their FQHCs, migrant health centers, WIC agencies, as well as the public health systems or the private medical groups in Michigan. We also received the cooperation of our Michigan Department of Education. School principals, superintendents, and our school secretaries received the parent letter. And we asked all of our partners to further distribute this, either hard copy, but even better, using the available technologies that are electronic, to include newsletters, emails to parents, posting it on school or practice websites, social media postings, as well as school and the parent portals and patient portals using the EMRs. Another approach that we're advocating is the use of through our Michigan High School Athletic Association in the school athletic offices, where the pre-participatory forms are picked up by athletes and their families. Several strategies are available to these partners, and many of our local health department immunization staff, as well as our vaccine for children providers, have already been aware of them pre-pandemic. But some people receiving these letters may be external partners that may not be aware of all the available resources and strategies to assist them. Next slide. So we have several different entities that are, or things that are available to our partners and our stakeholders. One is we want to make sure that they know what support is out there. So this slide shows about talking about delivering an effective vaccine message. We know that effective vaccine messaging is key to vaccine acceptance. Next slide, please. We also know that creating a culture of immunization is important to practices, health systems, and health plans. First of all, it helps us to protect patients through full immunization coverage and on-time immunizations. Second, research from CDC as well as others has shown time and time again that it's the healthcare professional that parents most trust. That's the parents' most trusted source of vaccine information. So we need to be sure that we're conveying the right information that will get to our patients and parents. We also know that parents are more confident in their healthcare decisions when they receive the same information from different people. Parents can get confused and lose trust if they're hearing different messages from staff. For example, if one person strongly recommends a vaccine, but then another one says that she chose not to get it for her own children, that can create questions in the mind of a patient or parents, and they can lack the confidence in getting the vaccine. Next slide. We know that doctors, nurses, and even medical assistants give the vaccines, but they're not the only ones who are responsible for creating that culture of immunization. Everyone that's connected to a practice, a clinic, or a health plan plays a part. It starts at the top with leadership, having that support and encouragement to have a vaccine policy and to perform best practices, so that the front desk staff, when they interact with the patients and parents, has a positive, strong vaccine message, and then it extends into the waiting room, the exam room, and then also finally to the checkout desk. All staff can work together to ensure consistent messaging are being communicated to both patients and their parents. But what actually do we need to do? There are 10 concrete steps that can be taken, and we'll see this in the next slide. These 10 things I'm not going to go through in detail. You'll have a copy of the slides after today's town hall call. But these are 10 things that have been proven to help create the culture and increase vaccine confidence, which will have a result in increasing vaccine administration. Next slide. As we know, many parents and patients have questions about vaccines, but so do staff. So we need to make sure we give them resources and that they know where to find them. Laura showed several different websites and other places to find resources. What you see on the screen is also another place. Next slide, please. So giving that strong positive recommendation for immunization, staff including providers, nurses, MAs, and the non-clinical staff need to know how they can give that strong positive recommendation. And the bullets on this slide show that. There's a presumptive approach that is used. It's been used very heavily with HPV vaccine, and it works as well for adolescent vaccines. And we're starting to see how it might work also to include the EUA approval of the COVID vaccine. Next slide. So working together is key. Michigan's making strides to get back to normal. So I thank you for letting me talk. I think we've got a lot of great approaches, and hopefully some things in this presentation today will help you also. Thank you.
Stephanie, thank you so much for sharing with us today your experience and hopefully some ideas that other states can take home as well. Of course, feel free to chat type questions into the chat at any time, and we'll do our best to get to them. But I want to keep us moving and introduce our next speaker today, and that is Amber Chris, the Directing Attorney with Justice and Aging, a less typical collaborator, but a really important one. And she's going to talk to us about Medicaid home and community-based services. I know this is a question that we've gotten a lot of feedback on over the last few calls, especially with some of the provisions in recent legislation. So we want to make sure that we had a real expert helping us navigate this. So Amber, I'm going to turn it over to you.
Thanks, Amy, and thanks for having me here today. If you go to the next slide, you can read a little bit about us at Justice and Aging. As Amy noted, we are not your typical organization to be speaking about maternal and child health access, but we are working really closely with the ARC of the United States on our Medicaid HCBS advocacy. And so I am filling in today for Nicole Jorwick with the ARC, but hopefully Medicaid HCBS is something that is applicable to all individuals of all ages with disabilities. So I hope I can answer all of your questions if you have any. So on the next slide, I just want to do some basic table setting to make sure that we're all on the same page. So Medicaid home and community-based services are really the backbone of these types of services in our country, the primary payer of home and community-based services. And these are those services that help people with disabilities of all ages live independently and in the community, and prevent unnecessary institutionalization, either in some sort of congregate long-term care facility that can take a whole bunch of different forms. And examples of some of the common home and community-based services include personal care, with assisting with activities of daily living, like getting dressed and bathed, helping learn social and daily living skills, supported employment. It can be legal services and home modifications, just all over the board, really comprehensive services. And for children in particular, the Medicaid program really subsidizes and supports sort of those early intervention and school supports, and meets those needs of individuals who have high support needs or high medical needs. Again, with the goal of being able to remain living at home and integrated into the community and in school. Next slide. But in Medicaid, there are major gaps in access to HCBS. And this is primarily due to what we call the institutional bias. And that is because under the Medicaid program, home and community-based services are optional. States do not have to provide them, although all states offer some level of HCBS to all populations. The fact that they are optional, whereas nursing facility benefits are a required benefit under the Medicaid program, creates enormous inequities in access to HCBS. So we see wide variation from state to state. We see long wait lists in some states. And then we see inequities based on age, on disability, based on race, and then of course, based on where you live. So maybe it's rural in your state, or sometimes, you know, you cross the state line and you're going to lose services that might be on a wait list for 2 years or 8 years. So just wide variation from state to state. And if we go to the next state, our next slide, I can show you some of that variation in play. So I picked some of the states that have historically and continuously spent less on HCBS than on institutional care, and then some of the states that have been spending more on HCBS than on institutional care, and then sort of the wait lists in those states, in particular focusing on individuals with autism spectrum disorder and individuals with an intellectual or developmental disability. So I normally focus on older adults, but I pulled out the data for this population in particular. And you can see in Iowa is spending almost 92% of it, or 82% of its funding on, or 88% of its funding on long-term care and institutional type settings. So congregate care settings of some sort for this population. Meanwhile, you have a state like Michigan and Oregon that are spending 100% of its funding for this population is going towards home and community-based services. So we see everything in between there, right? From the very lowest state at 11.7 up to 100%. And then we see the kind of waitlist enrollment, and that really varies, because I just want to emphasize that waitlist can be a proxy for unmet need in a state, but not all states maintain waitlists. So they don't have a wait list or registry for folks. And sometimes even if they do have a wait list, it doesn't actually measure that unmet need. Because even if we look at Michigan, where they're spending no money basically in their Medicaid program for this population on home and community-based services, they have 0 people on the wait list, but you know that there are individuals in the state that still aren't getting access to those Medicaid home and community-based services. So the waitlist can be a proxy for unmet need, but not necessarily a full proxy of that unmet need. So if we go to the next slide, the reason I kind of wanted to share the kind of variation is that we want to make sure that we're maintaining what HCBS infrastructure we have in place. And COVID really tested that infrastructure. And so from the outset, advocates had been pushing Congress to include in the COVID relief packages additional funding specifically for home and community-based services. And we were pushing for that funding from the very outset, and we weren't successful in getting it until this latest relief package was passed in March. And that was the American Rescue Plan. And in it, it included a 10% increase of federal dollars, so the federal matching rate for the Medicaid program, or FMAP, to specifically fund home and community-based services. So this 10% federal increase comes in addition to other FMAP bumps that have happened in the COVID and other COVID relief packages, and also on top of other federal match increases that states might get for other types of programs. So this 10% increase is for 1 year of expenditures from starting April 1st through March 31st of 2022, but states actually have the ability to spend that funding up until March 31st of 2024. In total, states and all states combined will receive approximately estimated between $11.4 billion to $12.7 billion in increased funding, specifically again for HCBS. There are strong maintenance of effort provisions in the funding, meaning that states are not allowed to make eligibility standards stricter than they currently are as of April 1st. They must maintain coverage for HCBS at the same level that was in effect as of April 1st. In other words, the states are not permitted to maybe reduce the number of waiver slots it has in an HCBS program, and then get this 10% increase, and then basically supplant that cut. So the whole point is that this funding should be building upon the current HCBS infrastructure and strengthening it, rather than supplanting cuts that the state might be proposing or had intended to propose. Finally, states cannot reduce provider reimbursements that were in effect as of April 1st, 2021. Sorry for that typo there. Again, the goal there being that we should be building on and strengthening our HCBS infrastructure, because I think what was shown in COVID was just how critical that infrastructure is. The pandemic exploited the gaps in that system. And so we should be building and strengthening it and not allowing backslides, but rather making sure we have a workforce that is supported and adequate access to services and supports. Again, because there's such wide variation in states' programs and also in the size of states, what funding we see states getting under the American Rescue Plan varies a lot as well. So if we move to the next slide, and I'm sorry this is so tiny, I had to cut and paste a small infographic, but you can take a look here that you have a state like California that has a pretty robust HCBS infrastructure, a lot of different programs, but also an enormous state is getting about $2.1 billion. And then if you look at a state like, let's say, Mississippi, for example, it's getting about 53 million, which is a smaller population state, but also has done historically less investment in home and community-based services. So kind of twofold, getting less in that federal funding. Nonetheless, a 10% increase specifically for HCBS is a very helpful bump for all states, and can really help to strengthen the services and programs and overall infrastructure in those states. So next slide, just some examples of what the CMS guidance is permitting. So CMS released guidance earlier, or back in the end of May, and I'm sorry, I didn't cite to it, but there was a link to it on the previous slide, and it's also at the end in the resources section. But they included a pretty extensive list of permitted activities that are allowed, that states are allowed to propose in getting this funding. It is not intended to be an exhaustive list, and I've only put a few of the categories here, but the guidance spells out a lot of different ideas. So they kind of broke it into two different buckets, sort of COVID-related HCBS needs, and then going beyond COVID, sort of HCBS capacity building and rebalancing reform. And so you can see here that the states have the option to actually increase covered services. So maybe expanding a waiver program so that it has additional slots. You could have HCBS programs facilitate COVID vaccine access, which we've been talking about a lot here, or provide COVID education and outreach. States could decide to better compensate its HCBS workforce, which is right now a lot of the HCBS workforce is receiving so little in reimbursement payments through the Medicaid program that they themselves are living in poverty, which makes it really difficult to maintain an adequate workforce, and therefore that limits the amount of access to services folks have. States could use it to reduce those wait lists. They can also use it to do things that are kind of administratively oriented, like streamlining application and enrollment processes, or improve oversight and data systems. So a lot of ideas that states can incorporate into their narrative and funding plan. So if we move to the next slide, you'll see that the timeline is pretty tight for states to submit their initial spending plan and narrative. They have 30 days since the release of the guidance, which is actually June 12th, which is right around the corner. But CMS did indicate on the call after they released the guidance that states can request an extension until July 11th, so a 30-day extension. So can receive an extension until July 11th. And I think it's probably, I can imagine a lot of states doing that. This is a fairly big undertaking to come up with this plan. And CMS is encouraging, though not requiring, states to include stakeholders in the process. So I think it's important that that does happen, because I think stakeholders will have a lot of ideas about what this 10% could go towards in your individual states, because each state looks very different. Their HCBS program looks very different from state to state, as well as the populations look very different, and the unmet need or the growing need might look very different from state to state. And stakeholders understand that best. Stakeholders like all of you, and also all the stakeholders that you all work with as a state agency on the ground. And for justice and aging, one of our main concerns is ensuring that we are centering equity and thinking about how this funding can be used. So what populations are not, in COVID in particular, who was most harmed? Where can we increase this funding to fill those gaps and make sure we get back up to at least the status quo and not and above, to start address some of those inequities in access to HCBS that we see across populations and across race and age and disability. So next slide. I wanted to, so that's the American Rescue Plan and the 10% funding, but I wanted to fit that into the broader context of what's happening with Medicaid HCBS. So we really see the 10% as sort of stopping the dam from breaking and making sure that we maintain that HCBS infrastructure. And that then we can build on that and do that through the legislation that, well, first, the commitment that has happened in the American Jobs Plan. So the American Jobs Plan, in that President Biden committed $400 billion and increased Medicaid HCBS with the goal of both expanding services and investing in the workforce. And just to give some scale, that $400 billion represents a 33% increase in annual HCBS spending over a 10-year period. So each year there would be a 33% increase in annual spending. And over the last 5 years, there's only been, almost 10 years, there's only been about a 5% increase in HCBS spending. So this would be a transformational influx of investment into our Medicaid HCBS infrastructure. And the idea, of course, this has been reiterated in the budget. And so we were talking about the budget earlier. So in President Biden's budget proposal, he also said that this $400 billion should be included, and it was included there. And he is committed to this, but of course, again, it's the legislature, it's Congress that will make this happen. And we are uncertain of what that will ultimately look like. It could happen through a bipartisan infrastructure agreement that talks are underway right now. It could happen through reconciliation process, or it could not happen at all. But the idea is that this would be a major influx of HCBS spending that would really help to make these services more widely available and start to address some of those inequities across the states, so that you're not moving from one state to another state and not having access, or if you move to another state, you have access where before you didn't have it. So addressing some of those inequities. And then finally, I wanted to touch base, give a little update on the next slide on the HCBS Access Act, which we think is sort of, if we're thinking about building blocks, we have the 10% FMAP increase in an American Rescue Plan, then we have the American Jobs Plan, $400 billion investment, and then we have the HCBS Access Act, which would actually make Medicaid HCBS an entitlement, and instead of an optional benefit like we have today. So just like nursing facility coverage or long-term care coverage in institutional settings, that is currently an entitlement, we would also make HCBS an entitlement. So then we wouldn't have these waivers with just limited slots, that if you met the criteria for eligibility, both financial and medical need, you would, and functional need, you would be eligible for those services. So on that front, the draft legislation was introduced for comment in March. There's no timeline right now as when that bill will ultimately be introduced. But again, it would build off the foundation of the $400 billion investment in the American Jobs Plan. So I will end there, and I provided some resources here at the final slide that includes that CMS guidance from the American Rescue Plan. And then the Kaiser Family Foundation put out a report that includes a breakdown of what that 10% funding increase looks like, and a better, easier to read summary than the guidance is to read. And then I also included a Kaiser Family Foundation report about Medicaid's role for children with special healthcare needs, just to get people thinking about like what this 10% increase could look like. What areas of HCBS might you want to focus on that are based on children with HCBS needs. And that's it. Thanks, Amy.
Thank you so much, Amber. And again, if anyone has any questions while our panelists are still on, please feel free to type those into the chat box and try to do it so that all panelists and attendees can see those. So far we have a thank you. And while we're waiting for, we have a comment from John, who's one of our AMCHP board members. Thank you for the presentation on HCBS work in the current plans and upcoming legislation. We need to highlight the need and the benefit of this for children with special health care needs and their families. And then we have a question from Allison. Are there any efforts to mandate state reporting on HCBS waivers? Amber, do you know the answer to that? You're muted.
I double muted myself, sorry.
Waiting list,
on the waiting,
specifically, she means,
yeah. So there's a lot of effort to get more data transparency from states. There is so little data about HCBS that CMS requires from states, and then that is being reported back out publicly. So from waitlist administration, which varies significantly from state to state, to the extent that some aren't even really waitlists, they're just like a registry. And so thinking about like, how do we make that waitlist administration and waitlist process more transparent to who is getting access to HCBS. We don't have even the most basic of demographic data from age or disability or race or location by zip code or county level. So we are all pushing for more data transparency, especially if we're tying it to increased funding, right? That there should be transparency along with these dollars to ensure that states are actually addressing this unmet need. And how can we make sure that states are addressing that unmet need if we don't have any baseline to compare that to?
Thank you. Feel free to keep typing in questions, but I am going to quickly turn it over to my colleague, Ben Kaufman, our Associate Director for Workforce, to let you know about some upcoming AMCHP events and opportunities, I should say.
Thanks, Amy. This is Ben from AMCHP. Hi, everybody. Apologies for the casual dress. I did not know I was going to be on the call today, but this is 2021, right? So I just wanted to share a couple of different opportunities that we have for leadership and workforce development for AMCHP members and those affiliated with Title V programs. The first is our Leadership Lab program, which I know some of you have participated in this most current year or in previous years. This is our flagship individualized leadership development program. We have 5 different cohorts based on the roles that you have and the settings in which you practice maternal, child, and adolescent health. But it's a really great opportunity for peer-to-peer learning and networking. It's a combination of didactic content, small group discussion, activities. We use an individualized leadership development plan, so this can align really well with some of the professional goals that you've established with your supervisors and with your teams. And it really is an opportunity for you to step back and think about yourself in a context in which we're always thinking about other people and really figuring out how to fill your cup. And we do that in ways that are supported through mentorship and through having AMCHP staff cohort leads. So it's a really dynamic program. It's about a year long. It's 8-10 months, sort of depending on when our conference is. We're accepting applications now through June 8th, so it is a quick turnaround. But there's more information on our website. Just click on, actually, if someone could throw the link in there, that would be really, really, really great. Or I'll try to do that right after I finish. But that's a year-long opportunity that runs essentially July through next April, May timeframe. And there's an opportunity for, thanks, Jess. There's an opportunity for an in-person gathering at our conference, and everything else happens virtually on a monthly basis. Can someone advance to the next slide? Perfect. So a more
Actually, Ben, can I interrupt you for 1 second?
Sure.
We did have a question from Martha about whether there are if there's a plan to share ongoing Leadership Lab webinars or offering resources with previous Leadership Lab participants, because the Leadership Lab webinars and offerings and resources were invaluable.
Oh, thank you, Amy, and thank you, Martha. Yes, so one thing that we have started with this past year of Leadership Lab is trying to make all of the sort of core topic focused content that we're offering available to the public. So the ways that we're doing that, one, are opening up, we do, depending on the year, 3 or 4 webinars that are public that are on topics of significance across MCH. So examples from last year include racially just and equitable MCH practice. And so we'll make those live learning opportunities available to anybody, not just AMCHP members, but anybody in our broader MCH community. And then what we do with that content is transfer that into material for the MCH Essentials series that we just relaunched last week. And so we take the content from those webinars, chunk them out into instructional little bits, and supplement that with readings and videos, ideas for activities and professional development. So all of that will continue to be available to everybody. But the difference between accessing those and participating in Leadership Lab as a participant is the access to those peer learning, those more intensive peer learning sessions, having an individualized leadership plan, and receiving one-to-one and small group mentorship from established Title V professionals. So we try to have something for everybody, recognizing not everybody has the ability to make that longer term commitment, but for those who are, it's hopefully a transformational process. Thanks for the question. And then the last thing that we have available for folks right now that are bi-weekly on Fridays from 2 to 3 p.m. Eastern are our MCH COVID coaching cafes. This is an opportunity to connect with folks who are associated with the MCH Workforce Development Center at UNC, who we collaborate very, very closely with and have a lot of experience helping Title V professionals address change management and adaptive leadership issues, which are things we know that everybody has been challenged with during this pandemic and as we move from response to recovery. So the idea is come with a challenge. It doesn't have to be super discreet. It can be just coming to process out your experiences and having some folks who are trained in addressing those challenges to come and offer support with things like coping with stress, safety and politicization, partner engagement, and just dealing with disruption in general. So you'll get some combination of one-to-one and small group coaching in that session, with the opportunity perhaps to start a dialogue with that coach in the longer term if that's something that would be of interest to you. So that's something we're making available bi-weekly, at least between now and the end of July. So highly encourage you all to sign up for that. And I don't know if someone put something in the chat, Jess or someone else, if you can find the link to sign up for that. But hopefully that's something everybody feels like would be a valuable use of their time. So thanks, Amy, for the opportunity to share, and looking forward to working with all of you.
Sure thing. Before we wrap up, I'm going to turn it over to Jess to share another opportunity.
Thanks, Amy. Yeah, I just wanted to briefly mention that another notice of funding opportunity for you to consider is the Pediatric Mental Health Care Access New Area expansion, and I can chat in this link in the slide. Applications are due July 6th, and it's just a really great opportunity to think about how to better serve children with mental health challenges. Thanks, everyone.
Thank you. Well, thank you to all of our wonderful presenters today. Hope you'll be able to take advantage of the resources that they shared, the resources that we just announced among different AMCHP opportunities. And I also want to remind you all our next call will be Thursday, July 1st from 2 to 3 p.m. Register. You may have been able to register already when you registered for this call. Thank you so much for joining, and we'll see you all next month. And check out the chat for a flyer about the COVID CAP days.